So good morning, everybody. This is, I believe, one of the very first sessions for the 25th Annual ThyCa Conference. So thank you, everybody, for joining us. I'm really excited to be able to introduce a fabulous Dr. Cabanillas. She is an oncologic endocrinologist at University of Texas, MD Anderson in Houston, Texas. She's a tenured professor, a faculty director, and a clinical researcher in the Department of Endocrine Neoplasia at MD Anderson. As a clinician and a clinical researcher, she treats both early and advanced thyroid cancers, including medullary, differentiated, anaplastic thyroid cancer patients. Her research focuses on advanced and aggressive thyroid cancer with an emphasis that includes molecular targeted therapies and immunotherapy. Dr. Cabanillas led the effort to create FAST, the Facilitating Anaplastic Thyroid Cancer Specialized Treatment at MD Anderson, which is a multidisciplinary group who sees the highest volume of anaplastic thyroid cancer patients in the nation. In 2022, she became the recipient of the Beverly and Jack Randall Prize for Cancer Treatment for this comprehensive and innovative treatment program for anaplastic thyroid cancer, which has led to nearly threefold improvement in the overall survival rate of these patients. Dr. Cabanillas serves as a principal investigator on several clinical trials for the treatment of advanced thyroid cancer and has completed her service on the 2021 Anaplastic Thyroid Guidelines Committee for the American Thyroid Association. She's been a member of the International Thyroid Oncology Group since 2012 and has completed her term on the board of directors in 2020.
Okay, thank you, Julie. It's great to see you this morning. I wish I could see everybody else. Hopefully someday we'll see each other again in person. I'm going to talk about anaplastic thyroid cancer, and I've titled this the MD Anderson approach because this is some of these practices are not widely accepted, and therefore, physicians who are treating you or your loved one may not agree with this approach, but I want to share with you how we manage ATC at MD Anderson. Okay, so just as a background, ATC does have the worst prognosis of the thyroid cancers. It's rare, thankfully. And what most patients, when they present with their disease, we can't meaningfully remove the tumor in the neck. What does that mean? It means that in order to remove the tumor, you would have to do a very drastic surgery where you would, remove the voice box, and possibly the patient would not be able to talk or eat normally, or basically you would leave tumor behind, which does not help ATC patients. It just sets them back from receiving effective therapy. More than half, it says here half, are metastatic at diagnosis, but I just came back from a meeting in Paris, and actually in Europe, what I'm hearing is that it's really more like 70% of patients are metastatic, meaning that it's spread to other organs outside of the neck. Here in the US, it's about 50%. And most patients are older when they're diagnosed. We certainly have younger patients, in their 30s, 40s, and 50s. So this is just the staging, so you understand what how we think about ATC. Basically, they're all stage 4 because they're all very aggressive tumors. But then we've divided into stage 4A, B, and C, which is on this up here in the blue box. 4A is basically that it's confined to the thyroid gland. These are usually what we call incidentally found, meaning you're doing a thyroid surgery because you think the patient has, a kind of usual type of thyroid cancer like papillary follicular, and then lo and behold, the final pathology shows ATC. These are almost never diagnosed before they go to surgery. Stage 4B are patients that have now tumor that's come out of the thyroid gland. So this patient, it's in the lymph nodes. Sometimes can be, invading into the trachea, into the esophagus, but they don't have any cancer outside of the neck. And then stage 4C, which are patients that have what we call distant metastatic disease, meaning it's left the neck, it's now in other organs. And so this is how we mostly have patients that are stage 4B and C, the majority are B and C. So I think for a very long time, we treated ATC as if it were one disease, and it's really not one disease, because ATC is basically kind of the end product of dedifferentiation, differentiation meaning how it started out, right, was a differentiated thyroid cancer. And within differentiated thyroid cancer, we have papillary, follicular, and Hürthle cell, which has now been renamed, making my life much more complicated, to oncocytic. But we're not going to talk about Hürthle cell today. The 3 differentiated thyroid cancers then can become poorly differentiated thyroid cancer, where it looks less and less, right? This looks a lot less like this. This looks a little bit like that, but it's lost the follicles. So it's less defined as a differentiated thyroid cancer, where the pathologist can say, oh yeah, that's definitely a follicular thyroid cancer. With poorly differentiated thyroid cancer, you can't really tell what the cancer of origin is, unless there's another part on that slide that shows follicular thyroid cancer. You wouldn't know how this originated from. And then the very end product of that is anaplastic thyroid cancer, where this doesn't look like anything that's in the differentiated or poorly differentiated category. They're very kind of disorganized tumors, and but what we've realized is that they're really still not one type of cancer. They don't behave the same, they don't respond to the same treatments, and they don't have the same mutation. And that's really important in order to be able to treat these patients effectively. Okay, so this is kind of the same schema, but it's top down, just to show that in papillary, the driver mutations, what we call what starts the cancer off, are mutations in BRAF, RAS. We can get fusions. In follicular, it's more RAS mutated tumors. We also see PAX-PAR gamma fusions, and then rarely in Hürthle cell, we see RAS mutations. And then what happens is that once it becomes less differentiated, it starts gaining more mutations. So it keeps that BRAF, for example, that it started out with, but then it gains a TERT promoter mutation or TP53. And these are what we call late event mutations. And then anaplastic just has more of those, okay? And this is just kind of to show you that we really do have what we believe are very different categories of anaplastic thyroid cancer, with the BRAF mutated patients having the best survival. So on a survival curve, you want to be at the very top. So in this blue color are the BRAF mutated patients. And then we have, basically everything else in the sense of how we treat these patients. But the patients who have the worst prognosis are in the RAS mutated category. So at the very bottom of that graph, those patients do the worst and the most difficult to treat. And then in the middle are patients that have neither BRAF nor RAS. So this is a kind of a broad category here, but their survival is somewhere in between the BRAF mutated and the RAS mutated patients. And some of this improvement in survival with the BRAF mutated is simply that we have a drug to match the mutation, right? So on the in what we call the druggable mutations are here in the kind of more dark yellow, are the BRAF mutated tumors, and then the tumors that have fusions in NTRK, RET, ALK, and then what we call non-druggable, meaning we don't have a drug that targets that particular mutation very well, are the patients that have RAS mutations, PI3 kinase, PTEN, TERT, TP53. But luckily, these tumors, the majority of these tumors, about 70%, express PD-L1. PD-L1 is simply a marker that we look at on the tumor surface, which tells us that the tumor is expressing it's sending out a signal to your immune system that says, ignore me. I'm not here, so just don't bother eating me, because I'm part of your normal body. And that's not the way the immune system is supposed to work. The immune system is supposed to recognize that there's something wrong in terms of like an infection or a cancer, and it's supposed to eradicate those tumors those cells before they become a big tumor. But these tumors have outsmarted the immune system and now are expressing markers that are telling the immune system to ignore them. So in a sense, there are, more patients in this category of non-druggable that we feel that we could treat with immunotherapy. These are actionable mutations. They're the BRAF V600E mutations. Most fusions are actionable. And then there are very rare TSC1 and 2 mutations that are possibly actionable. Okay, so in 2021, we finally came out with the updated guidelines. We've been working on these guidelines for years. And it's very difficult to do guidelines for rare tumors because you just don't have a lot of data. And there are not a lot of clinical trials, especially in ATC, where patients are so sick in the beginning, they oftentimes don't qualify for trials. But basically what the highlights of these new guidelines was that, as opposed to the previous guidelines from 2012, which started out saying, you've got to, basically most of these patients are going to die and they probably need to go to hospice. There's really not much we can do. That was basically, pushed down in the guidelines to a different section and starting out saying, we do have treatments for some of these patients and they need to be at least given a chance to see if we can treat these patients. And the other major change was that we recommended that all patients with ATC should have mutations on their tumors tested. So I'm going to discuss some of these emerging therapeutics that some of them are in the guidelines and some are not, and give you some very recent data that came from that Paris meeting that I just came back from. Okay, so let's start from the beginning. So back in 2014, we basically kind of made this leap of faith where we were no longer going to use the cookbook of surgery, radiation, and chemotherapy that every ATC patient was given, and that we were going to actually look at mutations and see if there was something there that we could target. And that targeted approach, the problem is that it can be very slow, it can be very complex. And when we took this leap of faith, basically by opening a clinical trial that was for the BRAF mutated patients, unfortunately, my first patient died waiting. And the patient died waiting because we couldn't get the BRAF results in time for him. And then he no longer qualified for the study because he was too sick. And so we quickly realized, like, we can't do this in a normal way, the way we do with most oncology patients, where you have the luxury of time to figure out what the mutations are. We need to go really fast in ATC and try and figure out who are the patients of the BRAF mutations. We can put them on the trial very quickly. So we moved from this, this very slow paced to a very fast paced way a very fast pace of doing things where we just gave everybody the cookbook to a very slow way of doing things. And that was really very challenging. So how do we get the mutation testing done very quickly? Well, the very first thing we need to know about is simply, do they have a BRAF V600E mutation or not? Yes or no is the first obstacle. And the way we do that is by staining. You just do a stain on the slide. At MD Anderson, because we have the stain here, which is an antibody, we're able to turn that around if we have tissue within 24 hours. Not every institution has this antibody on hand, so it can be longer. But we, at the larger institutions that treat ATC, they should have this stain on hand. The other very fast way of doing it is liquid biopsy. I'm sure many of you are familiar with. Liquid biopsy is just simply looking at the blood instead of at the tumor, because it's very easy to access blood where it's much harder to access a tumor. You have to biopsy, you have to set them up for the biopsy, they have to be off anticoagulation. There are all these things that you have to go through in order to obtain that tissue. Whereas with a blood test, just send you down to the lab. And then there's another way of obtaining the BRAF, which I've been highly criticized by my colleagues for not pointing out, is the PCR for BRAF, which is basically a mutation test for just one gene. The problem with this approach is that sometimes the insurance company will say, we're done. We did this gene testing on your patient, and now we're not going to pay for anything else. So if your patient doesn't have a BRAF, now you don't know what they have. So I'm not an advocate of single gene testing, but this is something that is done at other institutions. Okay, so I'm not going to go through all of this, but essentially just to show you that the time difference between doing a stain, that quick stain that we can turn around in 24 hours, this has come down to 24 hours. It used to take us, we used to get about 5 days. But now with the FAST program, we've basically made it part of the standard of care from the pathologist standpoint, where they do it automatically and we don't have to ask for it. So that's really improved from 5 days to 24 hours. But look at how long it takes to do a full genetic panel on the tissue. It can take more than 20 days. I mean, I don't know many ATC patients that can wait 3 weeks to get a result on the BRAF. By then, the patient's too sick to have any treatment. So it's really important that the BRAF status be determined very early on in the treatment. And the fastest way to do that is by immunostaining. Liquid biopsy is another way of shortening that 21-day period of the gold standard, which is to do all the mutations on the tumor. And what we do is we send a patient down to the lab. If we expedite it, we can probably get it within about 10 or 11 days. But these tests are also quite sometimes lengthy. They can take anywhere from 11 to 14 days. One problem with the test is that sometimes we miss some things on this test because it's a more focused panel. Fusions are hard to detect on these tests. And so it may not give you the full picture, but it is another faster way than waiting for the tissue to come to result. Just to tell you that liquid biopsy is just looking basically for DNA fragments that are circulating, and that is in ATC, we have a lot of release of this DNA in the blood. This was added to the guidelines for the 2021 guidelines, but it was kind of embedded into a paragraph. So they would not, make it like one of the, I can't remember what they're called, recommendations. So it's basically embedded in there and just says it's an alternative to comprehensive testing, but essentially, we need more evidence that it works before making it a recommendation. Okay, so recommendation number 4, basically just to show you rapid assessment of BRAF, and recommendation 5 is that all ATC patients should have the molecular profiling, that's the mutation profiling on their tumor, at the time of diagnosis in order to determine what the best treatment for these patients. Okay, so let's talk about therapy. We're going to start with BRAF. So remember that BRAF mutated ATC basically comes from a papillary that's been there for a long time, or that's been basically becoming more and more aggressive by gaining new mutations. In the United States, we see about 40 to 45% of patients have a BRAF mutation. In Europe, they're telling me 25%. So I don't know if this is because of a referral bias at the larger institutions. The patients that probably do the best are going to reach us the fastest. And so it's possible it's a referral bias. I'm not sure. It's also possible that we just have more toxins in our environment here than in Europe, where they control that a lot better. I don't know why it's so different. Okay, but let's talk about treatment. So ATC, BRAF mutated ATC study with dabrafenib and trametinib. This was a basket trial. That's the one I was telling you about back in 2014, where we were trying to do more targeted therapy. The original publication was 16 patients. Unfortunately, the patients had to be able to swallow. About 30% of my patients cannot swallow, and so a lot of patients were excluded from that study, but the response rates were very good. This is a waterfall plot. Basically, this is the change from baseline. So this patient, for example, had 100% decrease in their tumor and their target lesions, meaning that the tumors went away. And these other ones had, more than 30%, the yellows. And then these had some tumor shrinkage that didn't qualify as what we call partial response. And then this patient had worsening in the tumor. So this was, not sure why that happened. Okay, so this was approved in May of 2018, this combination. And then we did an update of the results because we had not met the median overall survival. And now we know that the median overall survival is 14.5 months. So the median is like the middle, right? They're going to be, half the patients are going to be living less than that time, and the other half are going to be living more than that time. But this was a major home run for anaplastic thyroid cancer, where patients essentially lived months, and they were lucky if they got to 6 months. These patients now were surpassing a year. But there is something that starts to happen within that 1 year. Within, I would say, between 6 and 9 months, you start seeing that patients are no longer responding to the therapy. And so that's called resistance. And you know, we have some understanding as to how that happens. But unfortunately, this study, which could have supplied a lot of that information of how these patients start to break through the therapy so we can figure out how to help the patient, we didn't get that information from this study. This is one of our patients at Anderson who was transferred into our hospital with a tracheostomy. The tumor was coming from out of her neck. It was coming through the skin. And then this is after 4 weeks of dabrafenib and trametinib. So these responses happen very, very quickly, and you can actually avoid a tracheostomy in some of these patients if you move fast enough. Okay, so resistance. Just to talk a little bit about resistance, what do we know about resistance? We published a small series of patients basically showing that these patients, they start out having a BRAF mutation, but then they end up keeping the BRAF mutation and then gaining some very bad mutations. So RAS is a mutation that we really don't like because we don't have any targeted therapy for it. And so we think that this is how these tumors break through, is that you're essentially kind of decreasing that BRAF population, and then if there's a RAS mutated population, then is allowed to emerge because you're not targeting that. So okay, then we started basically because of this problem with resistance. In this patient, the tumor was on her scalp, but oftentimes the tumor that starts to progress is in the neck. And so in order to avoid patient essentially being asphyxiated on that tumor after 9 months of dabrafenib and trametinib, we started taking these tumors out before that happened, because we know that every patient is going to develop resistance. So we need to be prepared. How are we going to manage that and maybe preemptive strike, right? Do a preemptive strike here, so that what we started doing was removing these tumors once they were small enough to remove, right? They had like these massive responses, and the thyroid became almost normal, and the surgeon could remove that. We actually did publish this. So if you want to look up that publication in Thyroid in 2019, essentially these first 6 patients, we have a larger manuscript coming out, a larger series, hopefully coming out within the next few months. And but basically what we showed in this series is that you could make this gigantic tumor, that all of this is the black tumor here, turned into this, and we're able to remove that tumor. This patient's tumor, much smaller, but essentially disappeared and had a normal thyroid, and then we took the patient to surgery, and so on and so forth. And so this is our approach at MD Anderson. We do this even with patients who have stage 4C disease, so what we call the distant metastatic patients. And that is not in the guidelines. Part of it is for the 4B patients, but not for the 4C patients. But we do think that this impacts overall survival. This is a retrospective study, but we do see that there are differences in survival in patients that went to surgery, who had a BRAF mutation, were treated with targeted therapy and went to surgery, versus the ones who did not have surgery. Because once that tumor starts to grow again and invade into the trachea again, there's not a whole lot you can do. Okay, so the ATA guidelines for 2021 now include that patients who have BRAF mutated unresectable 4B disease, and if radiation, chemotherapy, neoadjuvant dabrafenib are alternatives. Okay, so you don't have to treat them all with dabrafenib and trametinib, but neoadjuvant dabrafenib and trametinib actually got into the guidelines, and that was really quite difficult for us to get everybody to agree to that. So it is part of a possible treatment for stage 4B BRAF mutated ATC. Okay, so what do we do if there's no BRAF mutation? So more than half of our patients will not have a BRAF mutation. And this is not to scare you, but just to say that it's just all over the place. We don't really know what to do for these patients. There are some patients for example, if they have a RET fusion that may benefit from RET inhibitors. There are 2 selective RET inhibitors, and I'm sure you're going to have lots of talks on this at ThyCa. They're called pralsetinib and selpercatinib. We did publish this in the New England Journal of Medicine with selpercatinib. And the reason I'm showing you this study is because this is the only study that included ATC patients. They're in purple. It was 2 patients. Okay, 1 patient did very well, 1 patient did not, and died soon after. So we don't have a lot of information about using selpercatinib in RET fusion anaplastic thyroid cancer. It's great for papillary, for poorly differentiated, fantastic. But you know, I'm not so sure that treating with just selpercatinib or just pralsetinib is the right answer for ATC. Same thing with NTRK fusions. NTRK fusions are seen in papillary thyroid cancer, and they can be carried down to ATC. There are 2 selective NTRK inhibitors. This is now published, and you can find it in the European Journal of Endocrinology, of larotrectinib for NTRK fusion thyroid cancer. The reason that I chose to show you this is because they had anaplastic thyroid cancer patients, which are the green ones here. So this patient did not do well, but you know, you see that some of these patients did do well in terms of response. But here's what happens. Those 7 ATC patients, it's not a lot of patients, had a very short-lived response to larotrectinib. And their overall survival was 8.8 months, which, you know, is better than what we used to see, which is just a few months. But that's still not really very good. So my takeaway on this is that really single agent larotrectinib for ATC is probably not a great idea. And we should be using combination therapies. Just to show you that entrectinib also has publications, but we don't know which patients here had ATC. I do think there was one, but I don't know anything about, they didn't elaborate. So in the guidelines, it now says that if you have NTRK RET fusion ATC, that we suggest initiation of a TRK or RET inhibitor, preferably in a clinical trial. You know, the preferably in a clinical trial was essentially because these responses are short-lived. Okay, what if you don't have BRAF, you don't have a fusion, and this incorporates a lot of patients, and we tried lenvatinib in ATC. Lenvatinib is a drug approved for differentiated and poorly differentiated thyroid cancer. This was a single agent lenvatinib trial done in the United States. It was previously done in Japan, and they had very good results in ATC. And I have some theories as to why that is. But in the United States, we did not see very good responses. We really had only 1 partial response, and the trial closed for futility early. Median overall survival was only 3 months. So basically almost the same as without therapy. So I have a very strong opinion about this, and your doctors may not agree with my opinion, but I'm going to tell you my opinion today is that we should not be doing single agent targeted therapy in ATC unless it's for adjuvant therapy. So I know I've got some patients out there, they're going to say, wait a second. I'm talking about patients who have active disease where you can see the cancer in their body still. I don't think we should be treating those patients with just one therapy. So let's talk about immunotherapy. So immunotherapy essentially just teaches the immune system to fight the cancer. It's not targeting the cancer, it's targeting the immune system, your white blood cells, right? Those T cells that were supposed to get rid of your cancer before it formed. We're now activating them because the tumor is sending that signal of, don't eat me. And now we're going to remove that signal so that the immune system goes, oh, that's not supposed to be there, and comes in and takes care of or helps us take care of that tumor. Okay, so they did a single agent immunotherapy trial. These are also called checkpoint inhibitors. This drug, spartalizumab, is not FDA approved, so you cannot get it outside of a trial, and the trial is now closed. But it was this is a drug that targets PD-1, and 42 patients, global enrollment, response rate was 19%, which you go, wow, it's not very much. It's actually not bad, right? 19%. But the problem is that the median overall survival was only 6 months, right? So half the patients less than 6 months, half the patients more than 6 months, and only 40% of patients were alive at 1 year. Those aren't, great results. Like we're trying to get past that first year at least, right? But what they realized was something just fascinating, was that patients that had that marker that I talked to you about, the PD-L1 marker on the surface of their tumor, those patients actually lived much longer when they were exposed to the target, right? To the targeted agent. When they had the target or the targeted agent, I mean, it's logical, right? The ones that did not have PD-L1 expression on their tumor did very poorly. Okay, so now on to more recent data. This is actually from ASCO 2020 with a combination. So remember, I'm a big advocate of combinations. This is a combination of immunotherapy of the checkpoint inhibitor targeting PD-1, nivolumab, and then another checkpoint inhibitor, ipilimumab, which targets a totally different receptor, which is CTLA-4. And in the ATC, there were few patients, as always. These are small trials, but they saw a signal here. So 3 patients had a partial response, and then they show this beautiful example. This is the tumor, starts to go away after 2 months, 14 months, you can barely see it, and 26 months is gone. Again, not a lot of patients. The median overall survival had not been, where's the median overall survival here, had not been reached yet. And we don't have an update on this, unfortunately, has not been published yet. But I just came back from Paris, as I told you, from the ESMO conference, and there was a trial that was presented there with similar drugs. Durvalumab is like the kind of equivalent of nivolumab, and tremelimumab is kind of the equivalent of ipilimumab. Combining these two drugs, they had 12 ATC patients, and the ATC patients are here in green compared to DTC and MTC. Of course, they didn't do as well. The DTCs were had been treated heavily prior, so that's why their survival looks very similar to ATC. But the median overall survival in ATC was 13.8 months, which is almost equivalent to dabrafenib and trametinib. So, I do think that combination immunotherapy is a good option for some patients. What's in the guidelines? Basically, it says if the tumor highly expresses PD-L1, they didn't define what that meant. They didn't want to, and that you can use checkpoint inhibitors. But it didn't say, single agent, dual agent, because that data was not available when we published this. Okay, so for many years, when we realized that the patients were breaking through their targeted therapy, we decided to add immunotherapy at progression, and we started to see some responses. So we said, hey, why not just do this from the beginning? Like, why do I have to stress out about the patient? Am I going to catch them in time to start the immunotherapy? Is the insurance going to take 2 months to tell me if they're going to approve it or not? Let's just do it from the beginning. And so we started doing that. And this is another, I should have shown our data first, sorry. This is showing the Paris, the ESMO conference data for lenvatinib pembrolizumab. So remember that lenvatinib, very poor responses, but when you combine it, the ATC patients are in black. When you combine it with an immunotherapy, we start to see much better responses, 51%, which is fantastic. Compared to single agent lenvatinib, that's really good. And then if you compare the overall survival, 11 months, the median overall survival lenvatinib pembro versus 3 months with lenvatinib, difference of nearly 8 months. So this is what I should have shown first. Sorry, I'm very jet lagged, and I was doing this morning, but I wanted to show you our data with combining from the very beginning the BRAF MEK inhibitors, right? That it's a different combination because that we got sponsored by a different company that wasn't Novartis, but we used vemurafenib and cobimetinib, adding then the checkpoint inhibitor for these patients after a month. And if you look at our data and compare that overall survival, which hasn't been met, to what I call the doublet, which is dabrafenib and trametinib, there is a big difference here in terms of survival. And so again, I think adding checkpoint inhibitor to most things is probably the right thing to do. Okay, so it's I'm getting close to my end time. So I was going to first give you a summary, and then if I have time, I'm going to show you a few more things. But basically, the bottom line is BRAF status is critical. PD-L1 staining to me is critical. Every patient should have it, not in the guidelines. Molecular targeted therapy with immunotherapy, I think, is the way to go. And so we always try and do combinations. Resistance to therapy is inevitable. It's going to happen. Might as well be prepared for it. And then we need to keep enrolling patients in clinical trials. I know there's always this, people want to just take these drugs outside of clinical trial, and you can probably do it in the United States, maybe not in Europe or Latin America, but in the US, you can do it. Here's the problem. We'll never get these drugs approved unless we do it on a clinical trial, because the FDA is not going to approve it with just us telling them, hey, look, these patients, we treated them outside of a trial and they did so well. That's not going to fly with the FDA, and we need to get more drugs approved for ATC. Okay, so since I have a little bit of time, Julie, right, I can keep going?
Yep, you still can
Okay,
go.
a few more minutes. These are the trials that are open in the United States. I'm not going to go through all of them. I want to point out a few of them to you. But this slide just makes me smile, because when I started treating ATC, there was one trial that basically couldn't enroll any patients because, anyway, I'm not going to go into why it couldn't enroll any patients, but to see this number of trials for ATC just, melts my heart. I want to point out this study to everybody, because in case you're looking for trials, this is a phase 2 of a new drug by a company called Xencor, combining into one drug the PD-1 and CTLA-4, right? So instead of having to get two drugs, twice as expensive, we basically make it into one drug and give it to patients. There's this trial in ATC. It's open at Dana-Farber right now. We're trying to open it at MD Anderson. And then I think they're trying to open it, it's open at the University of Chicago. They're trying to open it at Dana-Farber, and we're trying to get ours open too. It also has an exploratory arm for Hürthle cell, just in case anyone has Hürthle cell out there. Another kind of practice-changing, hopefully, approach is going to be what we call adoptive transfer of T cells, which, you probably don't know what that means, but essentially it's engineering your white blood cells, the T cells, to start doing their job and fighting the cancer. And you can do that in a couple ways. One is CAR T cells. You remove the T cells from the patient, you engineer that T cell and give it this receptor, and then you infuse the CAR T cells to the patient and let the immune system do its job. Another way of doing this, this is the trial that's open now for CAR T. It's A1C100. It's open at Cornell and it's open at MD Anderson. And I don't know if they're going to have other sites or not, but this is for poorly differentiated and anaplastic thyroid cancer patients. And then, I'm sorry, I didn't mention it, but there is another trial that we have here with TILs, which are tumor infiltrating lymphocytes, where again, you remove the tumor infiltrating lymphocytes, and instead of engineering them, you basically just expand them. You have them like grow outside of the patient, right, in the lab, and then you give those back to the patient. By expanding that T cell population, hopefully then that gets rid of the cancer. Okay, so I think my time is up, so I will go ahead and take some questions now. I just want to show you this is our FAST team, which is rapidly expanding. There are people on that that are not in this picture, but we are trying to be able to see more and more patients, so we're really trying to expand the faculty who see these patients. But this is our dream team. Okay, so Julie, do you want to throw out some questions?
Yeah, we just have 2 questions, but you actually have 20 minutes left. So 10 videos. So if you didn't have a chance to get to something, you can go back to it really quickly, and then we'll start with questions. Do you want to do that, or do you want to go with questions?
No, let's go with questions, because I know there are always a lot of questions. Okay.
First question is, let's see, Dr. Cabanillas, you're my wife's doctor, and we really appreciate everything you've done for her. She's an ATC patient and on Keytruda. What's generally the length of treatment for Keytruda? She has no distant spread of the cancer, and her scans have been clear. What's the status of MD Anderson Keytruda with clinical trials?
Yes, so that's a great question. Let me share again. All right, so this is why I was saying, I think I shared on the wrong screen here. This is why I was saying basically, that we do treat some patients with
We've got
single.
your email right now.
Oh, I'm sorry. Don't read my email.
That's okay. It's quite small.
I'm trying to share again so you can see the clinical trial. I thought I closed my email. I guess I did not. I'm trying to share with you the clinical trials that that one that I put up, but now I can't find my share screen. Okay. I'm going to blame the jet lag here. I'm so sorry, but for some reason, oh, here's share screen. Okay. Do you see anything now?
Not yet.
Not yet.
Okay. I swear to you, I do this
Here
a
we
lot
go.
and I should know what I'm doing. Okay, how about now?
There we do. Yep.
You see the full screen. Okay.
Well, we see
So-
your notes
Okay, I'm sharing the wrong screen.
as well.
Okay, I just want to show you, I guess you're seeing the left side of my screen. I just wanted to show you that we do have a trial for stage 4B ATC patients. So remember that these are patients that do not have any active disease. We have already treated the disease, meaning the patient presents, we either have removed the tumor, given them radiation, or we've just given them radiation and their tumor's taken care of. Now we're trying to prevent patients from developing distant metastatic disease. Why? Because 70% of patients within the first year develop metastatic disease. So what we do is, we've been doing this outside of the trial, but we do have a trial for this in our institution where we give patients pembrolizumab for 1 year. And after that year, then we stop and wait and see what happens. Because what we're trying to do is activate that immune system, because immunotherapy is really good to like take out small disease, but not big disease. So we think that those 4B patients probably have a little bit of disease somewhere. And if you leave it there long enough, that's going to come back to get you. So it's like a preemptive strike. We're trying to get rid of any small volume disease by giving them the Keytruda, which is pembrolizumab, I should have said that before, for 1 year. So that's what we're doing in practice, and that's what we're doing in the clinical trial, which is now open. Okay, so do you want me to read the next one, or you want to read it, Julie?
You know what? You're probably better at pronouncing the names of those drugs that are not familiar to me.
Okay, I'm a 5-year ATC survivor on nivolumab and infliximab. At present, the cancer is held at bay, and existing 5 mets have shrunk to 4 millimeters from 2.5 centimeters each. My question is, should I get my cancer retested for mutations again? And the follow-up question is, would it make sense to be seen again by another doctor such as yourself, or do we leave good enough alone? Okay, so a couple questions in there. So basically, I'm surprised it's nivolumab and infliximab. I think you probably mean nivolumab, ipilimumab, I think. Infliximab would not be a treatment that we would choose for ATC, but essentially, yeah, so you're doing a dual immunotherapy, and I don't think that there's anything to biopsy to get your cancer retested for mutations. It depends. So 5 years ago, our panels were not that great. So I think that if they didn't find a target on that original panel, it might be good to go back and look at what they actually tested for to see, is there anything else that you can be tested for that could be a target in the future? But that's something you can discuss with your own doctor and just kind of go through that and say, do we need to have, if they didn't find a target only, should we go back and retest it on a different platform, on a more, advanced one? Every year these get better. I don't think you need to come and see us because they're, looks like you're doing well on this combination. I guess my only question, and I don't have an answer, is when do you stop this? Like, do we leave these patients on these treatments forever? And that's a question that I don't know how to answer. So if you came and asked me that in Houston, I probably wouldn't have an answer for you. I would say that, the patient's comfort level, if they want to continue, then continue. And if not, then you could stop and see what happens. I should have mentioned on nivolumab every 4 weeks. Okay. I think that's just a follow-up comment. Let's see, scroll down. How do you manage treatment for patients with comorbidity with autoimmune disorder? Yeah, that depends on the autoimmune disorder. It really depends on the status of the autoimmune disorder. So for example, a patient who has a history of colitis in the past, but is in remission without any treatment, I might ask my gastroenterologist to help me figure out whether I can put the patient on immunotherapy and follow them closely, because we can treat some of these things. If it's an autoimmune disease like, type 1 diabetes or Hashimoto's or vitiligo, or things that are not like, things that are not going to really matter for us, if we start immunotherapy, then the answer is yes. So it really depends on the autoimmune disorder. I was treated with radiation and chemo in 2018. I am in remission with no treatment, but watchful waiting. I'm BRAF positive. Should I be on other treatment? Okay, so I would reserve that BRAF MEK inhibitor treatment for when you need it. I do not use these drugs in what we call the adjuvant setting. Adjuvant means you've had your treatment, there's nothing else to treat, and now we're just watching you. Nowadays, I would have put a patient like you on the adjuvant pembrolizumab trial. But it's now since 2018. So the biggest risk is in that first year of relapse, and you haven't relapsed. So I would say just keep watching, still need to be watched closely. The first 5 years are the most critical. After 5 years, you maybe can be watched less closely. Watching closely in my book means every 3 months. As an ATC patient with metastatic disease, is all disease treated as ATC, or can some of the disease be papillary differentiated? Can ATC be localized to the thyroid only with papillary and say lung? Yes. So you can remember that ATC, in this case, I know the patient has BRAF mutation. So that ATC started out as a papillary. I know this because it has a BRAF mutation, and only papillary has BRAF, right? So remember that started out as papillary. It transformed in the neck, but it could have already spread to other organs and just be papillary and didn't transform in those other organs. So you can have both ATC and papillary. So might have taken care of the ATC, but you still have the papillary component, which is maybe not as aggressive, but they can be aggressive. And so we basically still call it all ATC and think of it all as ATC. Oh, infliximab to offset the effects of nivolumab. Thank you, James, for clarifying. Yeah, infliximab is actually not the treatment for your cancer, it's the treatment for a side effect of cancer. Okay. Jessica Jones, during the treatment, do you notice that the DNA fragments in the blood tests change in quantity? Are the liquid tests a marker of progression? So yes, when a patient is put on treatment, so for example, if the patient comes to me is already on a BRAF inhibitor, very unlikely that I'm going to find that BRAF mutation in their blood anymore, right? Because you're hitting the target. And so the amount of those DNA fragments in the blood are very low. You can use a liquid test for progression. And I didn't really have enough time to cover it, but we did present our data at ESMO in Paris just this week, where we looked at a test that's used in colon cancer for minimal residual disease, basically looking for that teeny tiny amount of disease. You can't see it on the scans, but it's there. And so we started using this test called from Natera. And the test essentially is a test that you do every time the patient has a CAT scan, because you're trying to see when the patient is relapsing before you can see it on the CAT scans. Why? Because that's the point where I can actually intervene and do something about it. This is a very small series of patients with medullary and anaplastic thyroid cancer that we looked at. So it's not really ready for prime time, but we were presenting our preliminary data and hope to have a better test for ATC rather than the standard liquid biopsy test, which is the one that I presented here, where we just do it one time to figure out what's going on at the time of either at the diagnosis or at the time of progression. With this other test, it's kind of a different concept because we're trying to catch the patient before things get really out of hand, when their disease is really, really small, where it's microscopic and I can't see it on CAT scans yet, but I can see it in their blood. In regards to rheumatoid arthritis for autoimmune disorder, okay, so patient with rheumatoid arthritis, if it's active rheumatoid arthritis, I probably would not put them on immunotherapy. I'd probably, try and find something else, but I would send them to the rheumatologist at MD Anderson to get their opinion on whether they think that immunotherapy is okay or not. So it's not a hard no, but rheumatoid arthritis is one of those that if it flares up can really be quite debilitating. And so I hate for my immunotherapy to do that to a patient, but we would be guided by basically the rheumatologist to tell us whether we can or can't. I think it really probably has to do with how active the disease is. Okay, Julie, do you see any other questions? I don't see any other ones.
No, I don't see any new ones that you haven't gotten to. Did you get to? Yeah.
Okay, yeah, and if you have any other questions, like Julie said, we can answer them by email.
All right, so I hate to think that we're finishing up 6 minutes early. Anything else you want to add, or?
Usually I have so many questions that I can't get through them, so I'm just surprised. I'm surprised that it's a quiet audience today. Where do you email? So Julie, maybe you can answer that question.
I can give that answer. So after the conference is over, any questions that doctors have not had a chance to answer during the sessions, you're going to be able to send an email to conference@ThyCa.org. And in the subject line, you want to include the session number, which this one is session number 104. And you want to include Dr. Cabanillas' name. So again, that's conference@ThyCa.org. And you will probably be told that at several sessions throughout the day. And
how do I get the questions?
They'll be forwarded to you.
Alert me. Okay.
Yeah. Yep. They'll send them to you.
Okay. And then someone asked, will this session be available to watch later?
It will. This session is recorded. So I don't know how quickly they're going to be posted, and people will get emails alerting them to the fact. Each year they get quicker and quicker. So whereas before it was a couple months, hopefully it'll be instead of a couple weeks, a couple days where things will start going on live. It's a good idea to subscribe to ThyCa's YouTube channel because you can always see conference data from videos from last year and previous years there as well.
Okay, so Julie, we have one more question. Do you have any recommendations for family members of an anaplastic patient who are now showing up with autoimmune thyroid disease? So the family member has autoimmune thyroid disease, not ATC. No, those are just completely different entities, and one has nothing to do with the other. I mean, they need to be seen by an endocrinologist, but other than that, it's not concerning, like for becoming an ATC patient. Oh, this is a great question. Would you ever consider an ATC patient cured? I do think we've cured some patients. And I say that with great caution because I've been heavily criticized for saying that we can cure ATC, but I do believe that we can cure some patients and that we have cured some patients. But only time will tell, right? Because, you know, they're essentially some patients that you are able to, for example, neoadjuvant patients where you put them on the dabrafenib, shrink their tumor down, remove the thyroid, and then either radiate or, you know, continue on other therapy. We give these patients immunotherapy too. And I do think that we've cured some of these patients. The reason is why I say I think, I don't know, is because we've not stopped their dabrafenib, the BRAF/MEK inhibitor. We've stopped the immunotherapy, but we haven't stopped the BRAF/MEK inhibitors because we're just kind of afraid to. And if they're tolerating it well, we just continue it. But I do think that some of these patients probably are cured. The only way to know is to take them off therapy and see what happens. And most patients are not willing to do that. And some doctors are not willing to do that. So the answer is, I don't know yet, but I think we have cured some. Of course, there are patients who, you know, have full resection with radiation and are cured, right? Like after 5 years, you know, it's very rare to see a relapse after 5 years. And so those patients are probably cured. And then there are the patients with, you know, metastatic disease that have been on immunotherapy that's been stopped and they haven't relapsed yet, but it's just too early to tell because they could relapse at some point and there's not hasn't been enough time to know that. What's the longest one can stay on Keytruda and what's next? There's no hard and fast rule. You have to stop at a certain point and stay on it for forever if you want. You know, as long as you're able to get the drug paid for by the insurance or the drug company. And so you know, I do take patients off Keytruda. For example, the adjuvant patients that I talked about, after a year, I stop it. If they have no disease, and, you know, we just watch things. The other situation is a patient who's been like on dabrafenib and pembrolizumab, which is Keytruda, for a long time. I usually treat those patients for 2 years, is my rule. They have metastatic disease, and then we can stop the Keytruda. So that's what I do. I don't think there's any set rule for that. What is poorly differentiated thyroid cancer? So I showed the slide where you're going from the well-differentiated thyroid cancer to poorly differentiated thyroid cancer to anaplastic thyroid cancer. It's basically just that the tumor becomes starts gaining new mutations that make it become more aggressive, and then that cause, you know, the tumor looks different under the slide. That's the best way I can describe it to you. What is considered advanced thyroid cancer? We actually defined advanced thyroid cancer this year in a manuscript with ITOG and Head and Neck Society. Essentially, all ATC is considered advanced thyroid cancer, no matter what the stage is of that cancer. And then patients who have like very bulky disease, metastatic disease, disease that's growing, you know, those patients are considered advanced thyroid cancer. How do you sorry, you want to ask something?
It's unfortunately it is 7:30 now, so we've got to end the session. I want to thank Dr. Cabanillas for her time and all of her valuable information that she shared with everybody. And again, if your question did not get answered, please send an email, and that information will be shared with you throughout the conference weekend. So thank you very much, Dr. Cabanillas, and have a wonderful conference, everybody.
Bye-bye.
Everyone. Bye-bye.